Hi everybody. Today we'll be looking at red eye. Red eye is not really a disease state. It's not a condition. It's more of a sign or a symptom of a condition. And even though this topic isn't heavily tested on the PBC exam, it's probably be a good idea to get familiar with some of the medications that are used for red eye, as some of these medications will also be used for other ophthalmic conditions. And red eye is a very general symptom, so it can be presented with other disease states. So let's get started. There are many causes for red eyes. Vitamin A deficiency can be one of the reasons, and autoimmune disease called Sjogren's syndrome could also be a reason why one could have red eyes. Blepharitis is inflammation of the eyelid. It's also known as stye. That can also cause red eye. And infection such as conjunctivitis. There's bacterial, and there's viral, and there's allergic conjunctivitis. That could be the reason why you could have red eye. And ocular inflammation, that's more of a serious condition. That's grounds for referral to optometrist. That could also be a reason. And more commonly, foreign bodies, corneal abrasion, smoke, and other ophthalmic drugs, rosacea. Those could also be cause for red eye. It's a very general sign, and so it can be presented with, like I said earlier, it can be presented with other ophthalmic conditions. It's one of the most common signs. So some of the other clinical presentation that occurs with red eye would be itching, redness, obviously, and there could be some discharge and pain, and rarely there could be some visual problems, but it doesn't always mean that it's a serious ground for referral or anything like that. These are just general clinical presentations, and sometimes some of these symptoms may present as just one instead of all five of them occurring at once. And some of the risk factor would be contact lens wearer. There oftentimes their eyes dry out, and they have to use lubricants very frequently in that case. Occupational exposure and allergen exposure is also common. And age, as you get older, your eyes just naturally dry up. In that case, you would also have to use lubricants. And if you have contact with somebody with bacterial or eye infections, that can also be increase the risk of red eye. This is an important thing. If somebody comes to you with red eye, but they also have severe pain or changes in visual acuity or any kind of visual disturbances, and if there also happen to be a contact lens wearer, or if there's been a known trauma or chemical injury, or unilateral redness, or recent eye surgery, you should. This is grounds for referral, no matter what. So these are some red flags that you should memorize. Non-pharmacological therapy. This is something that anybody can do. You should stop wearing contact lens if you have red eyes. Avoid applying eye makeup to avoid irritants. These are some obvious ones. And in situations where patients have viral or allergic conjunctivitis, you should apply cool compress. And bacteria most likely will require antibacterials. So in this case, we shouldn't do any compresses in bacterial conjunctivitis. If you have inflammation of your eyelids, aka blepharitis or styes, you can actually use warm compresses, and then and you use it for 10 to 15 warm compress for 10 to 15 minutes, and to your eyelids, and gently rub it along the lid margins with warm water. and that can be done on a daily basis before sleeping. Pharmacological therapies, this would be the most important part of the lecture, as there are a lot of different pharmacological therapies for depending on what the cause is. So in general, with viral conjunctivitis, we don't need eye drops, but you will see later on that there are products available for viral conjunctivitis, but it's not often used. We'll start with antibacterial for bacterial conjunctivitis, and I will discuss the algorithm, talk about the algorithm later on. So with bacterial conjunctivitis, it's caused commonly by H. influenzae, Staph aureus, and Strep pneumoniae, and in pediatric populations, and Catarrhalis. And one way you know that it's a bacterial conjunctivitis is generally it doesn't have much itchiness. Instead of itchiness, it has more of a purulent discharge. It's that thick, more yellow or green, or more of a milky discharge. That's more of a telltale sign of a bacterial conjunctivitis. And again, it doesn't have that much itchiness, and it has generalized redness. Again, purulent discharge. That's it. So when a question says purulent discharge, you should immediately think about a bacterial conjunctivitis. So look at some antibacterial. There are a lot of fluoroquinolone options: ciprofloxacin, moxifloxacin, ofloxacin, gadifloxacin, bezifloxacin. They're very popular, commonly used. And some acrylides, erythromycin. Fusidic acid is also another option. And there's polymyxin combination products, and tobramycin, which is a type of a gentamicin antibacterial. I don't believe you have to memorize all of them by heart. You just have to know that's some few examples and be able to recognize that, oh, it's an antibacterial. They will most likely not ask you like what to prescribe for these individuals, as this is more of a specialty field. But it's good to be aware of some of these antibacterial and be familiar with them, just so that you do realize that this patient has been prescribed antibacterial for a bacterial conjunctivitis. You should just be able to recognize some basic aspect of that. And as we said, we don't really prescribe anything for a viral infection, but there are options. One of them being trifluridine. This is a ophthalmic eye drop. There's also systemic antiviral, which is acyclovir, famciclovir, and valacyclovir. These are the same antiviral that's used for herpes. And so that's more of a random side note, and also a good way to memorize that they're used for red eye. And then ocular lubricant should always be used, no matter what. I think it should help. Doesn't matter what the cause is. So carboxymethylcellulose is one of the examples. I don't think you should memorize all these names off by heart, but it's good to be able to recognize them. It's only to that extent. Hydroxypropylmethylcellulose is another example, and mineral oil, petroleum, polyvinyl alcohol, polyethylene glycol 400, and sodium hyaluronate. They're all examples of lubricants that is safe for use for the eye. And if it's an allergic conjunctivitis, anti-allergy agents are used. There are antihistamines, and there's also mast cell stabilizers. So let's talk about the mast cell stabilizers first. They're sodium chromoglycate, lodoxamide, nitochromyl. And mast cell stabilizers, what they do is they prevent histamine release from the mast cell, and basically prevents an allergic response. So those are some of the examples of mast cell stabilizers. Another mechanism would be the antihistamine. This is more of a classic approach. It blocks the action of histamine that's already been released. Olopatadine would be one of them. I see olopatadine dispensed a lot at the pharmacy. Very commonly used. It's also commonly used in combination with a lot of like other antibiotics. And ketotifen. Ketotifen fumarate is also it's actually more. I don't see it as often as like olopatadine. It's a second generation antihistamine, and it also has a mast cell stabilizing action. So it's more of a dual action. So it has a powerful anti-allergy action. Ketotifen fumarate. I'm actually not sure on the spelling. You can always Google it and get the correct spelling. And we can look at the combination products, which are antizolene, which is a first generation antihistamine. That's combination with nefazoline, which is a vasoconstrictor. And vasoconstrictor just helps reduce the redness of your eye by making the capillaries smaller, so they're a little bit less obvious to see. So it's more of a symptom, kind of. It's more of a. It doesn't help with any inflammation or anything like that, but it's just more of a cosmetic type of drug. And phentermine is also an antihistamine, and that's also combined with nefazoline. And because we talked about these vasoconstrictors, there's other examples of ophthalmic vasoconstrictors other than nefazoline. There are also phenylephrine, which is commonly used decongestants, and tetrahydrozoline and oxymetazoline. The phenylephrine and oxymetazoline is a very commonly used decongestant for cough and cold, but in this case it's also used for people with red eye, and it makes sense because it shrinks the capillaries and makes your eye a little bit less bloodshot. And so that's it for sort of the allergic conjunctivitis. And ophthalmic anti-inflammatories. So you've probably heard some of these medications before in other contexts. These, especially NSAIDs, it's not good to use them long term because if you use NSAIDs, especially eye drop, long term, it can cause ulceration, and that's really bad. And so oftentimes, like, you don't want to use these medications for more than like a week. But this is up to the prescriber at the end of the day, and monitoring and follow-up is like really important when patients are on these medications. So diclofenac, ketorolac, nepafenac are NSAIDs. Also, for corticosteroids, anything that ends with ONE, S-O-N-E, or L-O-N-E, anything that ends with 1 is generally a corticosteroid, so you don't have to memorize like every single name of the corticosteroids. Dexamethasone, difluprednate, fluorometholone, loteprednol, prednisolone, remexolone. They all sound very similar. Some of them rhyme, so that's one way of memorizing them. And the most important part is monitoring parameter. The redness should disappear after 3 to 5 days of therapy. If they are still present, then you have to refer them. If they don't disappear after 3 to 5 days, there could be something else going on. So you should definitely refer them to an optometrist to get it checked out, or a physician. And some therapeutic tips are corticosteroids. When they use long term, they can cause glaucoma and cataracts. This is actually common knowledge, and so we obviously again don't want to use these long term. And you should always shake corticosteroid eye drops before use. And yeah, this is a very short topic. That's everything you really need to know for the treatment of red eye. I just want to go over the algorithm because I think it'll be very helpful in trying to keep everything together. So when a patient comes to you and they have red eye, you should first be looking at the discharge, if there is any discharge or not. If they do have any discharge and it's purulent, it's sticky, yellow, greenish, and let's say it crusts in the morning, then chances are it's bacterial. And in that case, you can consider topical antibacterials, one of the ophthalmic medications that we looked over. And if it's more of a watery mucoid discharge, then it could either be allergic conjunctivitis or viral. And the way you differentiate between those two is if there is severe itching. If it's severe itching, then chances are it is probably allergic conjunctivitis. Then in that case you can use ocular lubricants, one of the ocular lubricants that we have covered, plus vasoconstrictor and decongestants, or antihistamine and a mast cell stabilizer. And if it's more of a viral, because if you suspect that it's more of a viral because there isn't much itching, but there's a lot of watery discharge, in that case, you can go with the cold compress, like we said, for non-pharm, and we could consider using antiviral. I believe it was trifluridine, and obviously we would use ocular lubricants in all three situations. In general, in practice, you will not be diagnosing and prescribing for people with eye disorders, especially if you suspect that it's bacterial. You're gonna have to get either an optometrist to write a prescription for you, and so the most important thing is to be able to recognize medications that are being used at the moment. And so this was a short topic. If you found this lecture helpful, that's great. You can click the like button, and if you want to see more contents like this, you can subscribe. Thank you very much.